My name is Tu Nguyen Dumont. I'm the convener of the MPCCC Tech Talk series. For those who don't know me, I'm a cancer geneticist and bioinformatician and the head of the clinical genomics lab in precision medicine in the School of Clinical Sciences at Monash Health. To begin, I would like to pay our respects to the traditional custodians of the lands from which we join together today and acknowledge their elders past, present and emerging, as well as any members of the Aboriginal and Torres Strait Islander community who may be among us. To set the scene, the MPCCC Tech Talks aim to provide an informal and interactive forum for professional research community to discover and discuss the latest cancer research technologies and how they can be applied in a practical way to support our research. The Tech Talk format offers plenty of time for Q&A, and we really want you to tell us about your experiences, key learnings, tips and tricks, as well as any potential challenges and limitations. So today, I'm very pleased to welcome Heidi, a Victorian Cancer Agency Early Career Research Fellow at the Peter Mac, as our guest expert. Heidi currently leads the preclinical liquid biopsy research associated with advanced prostate cancer trials. Since completing her PhD in genomics at Monash University in 2020, her primary focus has been investigating the tumor genome in advanced prostate cancer to find cell-free biomarkers for novel therapeutics. Heidi is going to give us a short presentation about the necessary considerations and information required for successful design and analysis of circulating tumor DNA assays before we invite discussion from our audience. So can I please ask everyone to please mute your microphones and turn off your video to minimize disruptions. And thank you, Heidi. I'll hand over to you.
Thanks, Tu, for your introduction, and thanks for the invitation to talk today. It'll be a pretty brief talk, so if anyone wants to discuss with me even after the session today, I really love talking about cell-free DNA assays, so feel free to shoot me an email or anything like that, and yeah, hopefully we can set up some collaborations or we can help each other out. But I will get started if possible. Yeah, okay. So just a quick overview of what I'll talk about today. Firstly, to make sure we're on the same page, I'm just going to give a little brief introduction on what ctDNA or circulating tumour DNA is, when and why you should choose ctDNA, especially over what we consider to be the gold standard assay, which is solid tumour biopsy, what we can potentially use ctDNA for in the clinic, and if you are thinking about setting up your own assay, the technological considerations you should make in picking what sort of assay you should use. And lastly, the limitations and challenges to clinical use or clinical implementation of ctDNA assays. So cell-free DNA is present in every individual. It circulates freely in our blood. It predominantly arises from circulating white blood cells. So they release DNA into the bloodstream via apoptosis, active secretion, and also on some occasions netosis. So the cell-free DNA in the blood is highly fragmented and sometimes highly degraded. It's about 170 to 350 base pairs long. It has pretty short half-life of 16 minutes to 2 hours. And cell-free DNA levels can rise in healthy individuals or unhealthy individuals in, I guess, any situation where cellular turnover would be increased. So when you're unwell, have the flu, after intense exercise, and with physical trauma. And when I talk about ctDNA or circulating tumour DNA, I'm specifically referring to cell-free DNA that's released from tumour cells. So obviously only patients with cancer are going to have ctDNA. It's released from all metastatic sites of a tumour via apoptosis, sometimes necrosis and active secretion. As I mentioned, it's comprised of DNA from all tumour sites. and it is usually in the minority of cell-free DNA. So ctDNA is usually pretty diluted. So the identification of somatic variants in the DNA can be extremely tricky. So how do ctDNA biopsies compare to a solid tissue biopsy, which is considered the gold standard for molecular analysis? There are a lot of reasons for choosing a ctDNA biopsy, both in the clinic and as a research tool. Firstly, you really only need to take a peripheral blood sample, which is obviously a lot less invasive a procedure. It's way shorter procedural time, lower cost, and can be a lot more sensitive, especially for detecting minimal residual disease, which can be missed by conventional imaging techniques. Because you can take serial biopsies really easily, you can monitor continuous tumour evolution and real-time responses to drugs. You can have a look at spatial and tumour and temporal tumour heterogeneity, because one blood sample is going to give you DNA from all metastatic sites, unlike a single solid biopsy. However, it's not all rainbows. ctDNA assays aren't really clinically validated, or a lot of them aren't. You can't use them to give you any histological information or show you what the tumour microenvironment looks like, nor does it allow for any protein or RNA analysis. And if there's anything I wanted you to take away from today for ctDNA assays, is that they usually need to be really highly sensitive, because the tumour DNA is really dilute. So it's not the same as just taking a solid biopsy and expecting to find somatic variants at 50% or above. And another reason they can be better than tissue biopsies, especially if you've got bone mets, is that the decalcification process of a bone needle biopsy can degrade your DNA. And at least in prostate cancer or metastatic prostate cancer, you can fail to get enough DNA for a downstream analysis up to 30% of the time. So we are fairly confident, however, in terms of the tumour genomic landscape. ctDNA and tissue-derived DNA profiles are largely concordant, especially in cases with higher ctDNA levels in the blood, so late-stage disease or metastatic disease. So these are results from a study a few years ago in metastatic prostate cancer. They profiled ctDNA samples and tumour tissue side by side, and they were collected at around the same time point. Every single point mutation, somatic point mutation found in the tissue samples were also concurrently identified in the ctDNA sample. And the clonal hierarchy was remarkably similar, as you can see here, if you're comparing between the two, or the liquid and the solid biopsy types. Additionally, they found a concordance rate of 88.9% for copy number aberrations in clinically relevant driver genes in prostate cancer. And on top of that, and quite interestingly, in several patients, the ctDNA sequencing revealed additional driver mutations that were not detected in the tissue. And in one instance, the clinicians associated with this subject, with this project, successfully treated a patient with carboplatin based on a BRCA mutation that was detectable in the ctDNA. So hopefully this showcases the utility of ctDNA analysis and gives you some confidence, I guess, that at least as much information, you can get at least as much information from ctDNA as you can from a solid metastatic biopsy. And by that, I mean in terms of the DNA.
Certified, and so we thought
what someone was jumping in with a question. So there are a number of ways we can use ctDNA as both a research tool and in the clinic to improve patient care. So firstly, there's some utility in using it as a screening or diagnostic assay. There are a number of biotech companies out there now that are developing ctDNA assays as cancer screening and diagnostic tools. So one example is Genomics for Life. They have a pan-cancer assay, is what they call it, that performs targeted sequencing on hundreds of genes. There's a clinical labs test that can apparently screen for melanoma, colorectal and lung cancer. However, a lot of researchers, including myself, are a bit wary of these types of assays, as they don't publicly list sensitivity and specificity. And they also don't explain, I guess, that the research behind these assays. There's been a large effort in the research space in the past 6 or 7 years for a screening test called CancerSeq. So this combines ctDNA analysis with protein biomarkers, which is pretty cool. And they do actually list their detection sensitivity. It appears to be successful in cancers that typically have higher ctDNA levels in the blood, but such as ovarian and liver cancer, but it's clearly not ready for clinical implementation in a number of tumour types. So possibly with, I guess, the more we discover about tumour genomics, and if we can integrate other omics such as serum, protein, biomarker analysis, and as technology progresses, I think we can get closer to a diagnostic test for some cancers using a blood test. So I'm sorry, I know this slide is hectic. It's just to signify all the successful research going on across different metastatic cancer types to use ctDNA as a prognostication and risk stratification tool. So finding ways to easily identify high-risk patients is actually quite useful for clinicians. They can identify patients that are going to benefit from treatment intensification and save those that aren't going to receive any benefit from treatment intensification. And they can also perform closer monitoring of patients who are high risk. So the top row of Kaplan-Meier curves is to show that in prostate cancer, breast cancer, non-small cell lung cancer, and colorectal cancer, you can actually quantify the fraction of ctDNA to normal cell-free DNA in the blood. And patients that have a fraction of 10% and above have significantly short overall survival times, and that's irrespective of treatment received. On top of just looking at the broad ctDNA proportion in the blood, you can look at specific genomic markers that have prognostic significance. So for example, tumor suppressor genes, or even the number of hits in tumor suppressor genes has been linked to extremely poor overall survival. And in also another example, in the case of prostate cancer, androgen receptor mutations have been linked to significantly shorter overall survival times too. So using ctDNA assays to facilitate personalized therapy is perhaps the most promising use of liquid biopsies in oncology research. There's a lot of investigator-run trials and biomarker-driven trials out there that are online. You can read about that. I could go on for 100 years, but I'm just going to show the actual FDA-approved companion ctDNA diagnostics that are actually covered usually by Medicare or Medicaid in the US. So these companion tools can take a blood sample, the companies take a blood sample and they can return to the clinician within, within 7 days, a list of suggested therapies if the patient has a mutation that a particular therapy is approved for use in. And they've been quite successful, especially in cases where a solid biopsy fails a high proportion of the time, such as non-small cell lung cancer. So the first of these FDA-approved tools is Foundation 1, which assesses 300 genes. Second is Guardant360, it has 60 genes. And on top of screening for these particular somatic or germline mutations, what's interesting for us, I guess, as researchers is that they can be used also for general tumor profiling as well. So we can actually send our blood samples into them and obviously pay them, and they will return to us the sequencing data and any clinically associated data with the mutations that are found. And lastly, another use for ctDNA biopsies is to investigate treatment resistance biomarkers and using them to monitor patients for disease progression or to monitor post-treatment for relapse. So dynamic changes in ctDNA fraction from baseline to on treatment can potentially be used to indicate a response to therapy or a lack thereof. And because ctDNA has such a short half-life, it has the potential to outperform current clinical methods of detecting therapeutic response, such as serum biomarkers or imaging techniques. Additionally, it's been used in research settings to identify reversion mutations that will signpost acquired resistance. So for example, researchers have used ctDNA assays to identify BRCA2 reversion mutations in ctDNA in response to the selective pressure of PARP inhibition, and obviously gives an indication that the patient is developing resistance. And on top of that, you can also look at the increase in resistance conferring subclones, and also look at a number of other genes or gene targets at the same time, and potentially as you're monitoring for the development of clinical progression, you can identify novel drug targets at the same time for the next line of therapy for a particular patient. Another way, and really interesting way I think that ctDNA is currently being used, is to profile patients at the beginning of therapy with a really large panel to identify the dominant driver mutations just for that one patient. And then they quickly design a smaller bespoke panel for serial biopsy analysis. And they just use that smaller panel, which is a lot cheaper, to follow that small handful of mutations that they know the patient has over the course of therapy, or as a monitoring tool. So because a smaller panel is cheaper, you can sequence more, you increase your assay sensitivity, and that's a really good approach for minimal residual disease detection after treatment with curative intent or post-surgery, for example. Right. So if you're interested in working with ctDNA, there are a number of things I think that are important to consider first. Firstly, what kind of cancer and what stage of cancer are you interested in? If it's local disease, perhaps peripheral blood won't be as sensitive as taking a liquid biopsy sample from elsewhere. So I know I've only spoken about blood samples at the moment, but a liquid biopsy really means taking any fluid from a patient, and all fluids actually have ctDNA present or cell-free DNA present. So for example, ctDNA can also be found in urine. That might be useful to you if you're looking at localized bladder or prostate cancer. It can also be found in stool and saliva, so take that into consideration as well. However, if you're interested in metastatic cancer, a blood sample, I would say it's definitely the way to go. It's more likely to capture the heterogeneity you can see between lesions at different sites. And if it is blood you are collecting, make sure it is plasma in an EDTA tube, you collect plasma and not serum, as there have been studies showing that coagulants in the serum tubes compromise your ctDNA detection by increasing the amount of non-tumor DNA in the tube from cellular lysis. So basically the takeaway is do everything you can to reduce the likelihood that the ctDNA can become further diluted from lyse cells. So this means separating the plasma from the cellular components by high-speed centrifugation as soon as possible. To do that, you need access to the correct infrastructure. That's going to be a refrigerated centrifuge that can go up to around 5,000 to 6,000 G. Obviously a biosafety cabinet for human biospec processing, and also a -80 freezer, which is how you store the plasma. And if your samples are being collected off-site, which they often are, if you've got a clinical trial, for example, with multiple sites, and you're unable to process them within a couple of hours, I suggest you look into using cell-free DNA stabilizing tubes. So one example of those is the Strat tube. They are a lot more expensive, unfortunately, than the EDTA. I think at the moment they're around $10 a tube. But blood can be safely stored in these tubes for up to apparently 2 weeks at room temperature without compromising the ctDNA. So it stops all the other cells in the blood from lysing and further diluting the ctDNA, which gives you the time to have the samples couriered to you. And even though they should be transported cold, sometimes things go wrong. So even if they do warm up, the ctDNA is still going to be stable in the tubes. Something else I recommend you do also is to take a matched germline sample from your patients. So we collect the white blood cell layer from the blood tubes after we do an initial soft spin and freeze it down separately. And I'll tell you why I think that's important in a few more slides. So you've got your samples stored, and now what do you do with them? It's important, I think, to consider carefully about the research question you have before you select an assay, because the different approaches of analysis give you different information, and they have different limitations. So there are 3 main assay types that are broadly broken into PCR-based detection, such as digital droplet PCR, genome sequencing or next generation sequencing, such as targeted panel next-gen sequencing or whole exome sequencing, and also nanomaterials-based detection, which primarily uses gold nanoparticles. It's a fairly new and niche research area, and in the interest of time, and also because I know very little about nanomaterials, I'm going to focus on the two most common assay types, which are the PCR-based and NGS-based. So the PCR-based detection methods are what we call the low throughput approaches. You can usually assess between 1 and 10 genes or hotspots in the ctDNA. They have incredibly high sensitivity compared to the NGS-based methods. So ddPCR can detect 1 mutation in 100,000 wild type molecules. The data you generate from these methods is fairly low complexity in comparison. It doesn't take too much effort to analyze. It's pretty cheap. And most people are using these types of assays in conditions where you have known mutations, because you need to use specific primers. So these are useful research tools for instances where you need really high sensitivity. So screening and diagnosis, or in detecting relapse or minimal residual disease. On the other side of things are the next generation sequencing based assays, which are the high throughput approaches. They're actually becoming the most popular as sequencing costs are going down. They're much higher throughput, as I mentioned. You can sequence either a targeted panel of genes or the whole genome or exome. And there are a lot of people doing low pass whole genome sequencing on ctDNA analysis at the moment. NGS assays typically generate large amounts of data, as I'm sure you're aware. It can be very difficult to interpret and has high computational requirements and often needs specialized pipelines. But they are much more useful in terms of biomarker discovery or any instance where you don't know what genome mutation you should be looking for. So for instance, biomarker discovery or treatment selection for a patient. And you can also use them to determine tumor mutational burden or microsatellite instability status. And one other thing is to not only consider, I guess, what type of assay you need, a low throughput or a high throughput, but also what types of genomic alterations you want to find in the ctDNA, because some assays have limitations in terms of CNV detection or SNV detection. So, for example, low pass whole genome sequencing is not going to allow you to identify low frequency somatic variants. All right, so the bioinformatics consideration of NGS assays. The bioinformatics considerations, as I mentioned, are particularly relevant to the high throughput assays. I'm not going to embarrass myself by pretending to be a bioinformatician. I just wanted to point out, I guess, that variant calling pipelines have a lot of different steps. I don't advise you just put your ctDNA sequencing data through programs that were designed to identify somatic mutations from biopsy tissue, because they won't be sensitive enough and you'll just miss a lot of mutations. I've put up my variant calling pipeline that was set up with the help of Tu and Jason, who's a bioinformatician. I use this every day in my research on my prostate cancer samples. Feel free to screenshot if you want to get any ideas from it. So ctDNA data does need some special TLC, and there are no standardized methods at the moment, but there is a lot of literature out there to help you decide what your best options are, what filters you should be applying, and I also recommend you have a squiz on GitHub as well, because there are a lot of freely available analysis tools. One thing I do think is really important to mention is the importance of paired sample mode for variant calling. So NGS assays should always have a matched germline sample, as I mentioned earlier. So with each patient sample, plasma sample you have, you should also have a germline sample. So this is to be able to identify chip-associated mutations. So these are clonal hematopoiesis of indeterminate potential alterations. They arise in white blood cells and are more prevalent in increasing patient age. They are usually benign in terms of tumor oncogenesis, but they're a large source of biological noise, and they can often cause false positive somatic calls to occur. They can actually be present in at up to 15% variant allele frequency in your cell-free DNA sample. And they're actually quite common in a number of cancer-related genes, such as TP53. So all of the CHIP-associated variants are here in the little green dots, if you can see them. Also in ATM. So you can imagine that if you're not able to filter these out, you can have some this can have some pretty interesting effects on biomarker studies. And when some of the companion cell-free DNA tools came out, they were not using a matched white blood sample or a matched germline sample. So unfortunately, I think they were giving out a lot of misleading data in terms of especially TP53 mutations. So having this matched germline sample allows you to identify these as CHIP mutations and not somatic calls, and you can filter them out from your final variant list. All right, so I've mentioned a lack of sensitivity is one of the biggest challenges to ctDNA research and analysis, because the tumor DNA can be heavily diluted in normal DNA. So there are some ways to improve your assay sensitivity, I guess really easy ways to improve. Firstly, as I mentioned, trying to reduce cell lysis in your blood tubes by separating the liquid component from the cells as soon as possible. So you might read in the literature you can keep an EDTA tube for up to 6 hours before processing. That gives me hives. I'd probably do it within 2 hours unless you have a strep tube. So also trying to prevent contamination from other DNA sources, especially in the pre-PCR stage, because this can have a big effect if you take contamination into your PCR. Lots of people actually have dedicated pre and post PCR rooms and equipment to keep everything clean and separate. Wiping everything down with solutions like DNA Zap also can't hurt. And probably something I've noticed as well is if it's in a communal space, putting your I guess your pipettes and your plasticware and stuff away, because there's always someone that will come in and like just use your stuff really quickly when they think no one's looking, and that can really harm your assay if it's in the pre-PCR space. You can also buy pipette tips and EPIs that repel DNA to try and reduce loss of the DNA to the sides of tubes. And one particular method for increasing sensitivity in NGS assays in particular is this technology called molecular barcoding. So when I started my PhD, I don't know, 6 years ago, it was only just starting to be used in assays, but now almost every cell-free DNA library kit will have molecular barcoding. What it does is adds a step to library prep before any PCR takes place. So a completely unique barcode is added to every single DNA fragment in the pool. And this barcode is carried throughout all of the rounds of PCR, and it gets sequenced and included in your raw data at the end. So this means that bioinformatically, PCR duplicates can all be traced back to the same original DNA fragment they have come from. And in this way, you can perform a process called error correction, where you can use these PCR duplicates for good. You can collapse them down. It's called clustering and error correction, where you can remove these PCR and sequencing errors, presumably because they will be in the minority of PCR duplicates. And lastly, if you're using next-gen sequencing and you want to identify somatic point mutations in ctDNA, be prepared to pay up. Even though sequencing has gotten a lot cheaper in the last couple of years, especially with the NovaSeq or the Illumina NovaSeq. Depending on the level of detection you want, you may need to go up to around 20,000 x depth. Which I guess costs, I spend around $500 per patient sample on sequencing, and then spend at least that much on the wet lab stages as well with library prep. So it definitely does start to add up if you're doing a high throughput assay. All right. So before we get to the questions, what are some of the, I guess, shittier things to be aware of about ctDNA and the challenges and limitations, and I guess what we still face in terms of research questions for cell-free DNA in oncology research. So firstly, unfortunately, not every patient is going to have detectable ctDNA, and the proportion of patients with ctDNA that you can detect is going to go down with overall tumour burden as that decreases. And so, for example, in earlier tumour stages, so for example, concordance between a solid and a liquid biopsy in stage 1 tumours can be 0%. So most studies are being done in metastatic or advanced stage cancers for a reason, and ctDNA assays might not be a useful clinical tool in cancers that don't shed much DNA into the blood, such as thyroid cancers or brain tumours. Secondly, some of the assays can be really expensive, as I mentioned, which makes it difficult to assess a large cohort of patients unless you have a lot of funding. And thirdly, I'm sure this is obvious, we're only investigating alterations at the genomic level. We're only looking at the DNA. This doesn't necessarily mean there are changes at the protein level. So perhaps ctDNA assays should be used in conjunction with solid biopsy analysis, or probably even with other blood-based biomarkers where possible, which obviously increases the amount of work you have to do, the cost of the assays, but I think it might be where we're heading in the future. And yes, we can identify subclonal variants and variants in ctDNA down to 0.1% or lower variant allele frequency, but we still don't really know the importance of these kinds of mutations. And I'd be wary of making clinical decisions based on a really low frequency subclonal mutation. And lastly, there are no standardized protocols and pipelines. So it's still a little bit like the wild, wild west in ctDNA research. There's a lot more information we need to know before we can fully understand ctDNA, its dynamics, its release mechanisms, and how to best analyze it and put it to clinical use. All right, I am finished. These are just my funding support and all of the members of my lab that help me with my research. And I'm also recruiting. So if you're interested, or if you know someone doing honours, PhD, looking for a postdoc, please contact me. Thank you.
Thank you, Heidi. Wow, that was really great. It was a very clear presentation, very comprehensive. Thank you for sharing your experience. So we're going to open up for questions now. Please raise your hand if you have a comment or a question. Turn on your video if you can. Right, let me have a look. Any questions for Heidi?
Is anyone currently using a ctDNA assay or cell-free DNA assay in their research and has any gripes they want to air?
I think someone's trying to talk, but I can't hear you. Do you want to? Yes. Yeah, we can hear you.
Oh, there we go.
Sorry. Thank you for the presentation. My name is Yuri. I'm starting a PhD on thyroid cancer ctDNA. I was just wondering, with the Strep tubes, have you ever heard of refrigerating them? Like, I guess in the room temperature, sorry, in the manual it says you can keep it in room temperature. But scientists I work with at the lab I'm in says you can put it in the fridge just to preserve it a bit more. Have you heard of that before, or is that?
Yeah, so there are actually most people, when they do send them off in a courier, they should be kept cold because it's obviously safer to prevent cellular lysis. And it will last even longer, I think, than 14 days if you keep them cold. It's probably just as better to be safe than sorry, I think, putting them in the fridge. So it's definitely something you can do.
Okay, because the manual says 6 to 37 degrees. and the fridge is 4 degrees. So 4 degrees is okay, like it's not going to cause
Yeah,
any
no, 4 degrees
damage?
is fine. Yeah, there's a few studies where they compare refrigerating the samples versus leaving them at room temperature versus leaving them in case there's like a really hot day or something in the, I don't know, the delivery truck breaks down. So they have even looked at like 30 degrees and yeah, it's actually all pretty stable even if it gets really hot apparently. But I don't know about this 14-day business, to be honest. I'm pretty I don't know, I just would never do that myself, but I'm probably overly cautious.
In practice, it seems like it says 14 days, but it doesn't seem like it's, because when I first started my PhD, I needed supervision to process the blood, so I had to wait, and I thought, oh, I can leave it up to 2 weeks. But when it got to the end of the 2 weeks, the cell, when you separate the plasma from the red cells, the plasma looks very red. So there's probably lysis happening already.
Yeah, it's been hemolyzed. I probably wouldn't leave it that long. Yeah, I agree with you. I've never actually seen someone leave it 2 weeks, so it's really, really interesting. I guess it's like worst case scenario. Like if you do have to leave it 2 weeks, it's you can, because you have the Streck tube. Like obviously it would be completely kaput if you were using an EDTA tube, but if you have a choice, I would do it sooner rather than later, definitely.
And sorry, do you know the names of the studies that were comparing? You were saying something about comparing the Streck tubes, something.
Yeah, it's just a couple of papers I've read, and I'm not going to remember it off the top of my head, but if you send me your email or send me an email, I'll forward them to you.
Okay. Yeah, thank you. No, and with the EDTA tube, sorry, if you keep it in the fridge as well, does that sort of extend the sort of time, or how far would you?
So keeping the cells cold is definitely going to reduce the amount of cells that are lysing into the blood. A lot of processing protocols actually suggest that as soon as the blood has been drawn from the patient, it goes straight onto ice.
You should keep it on the ice.
Yeah, or at the very least, it could be spun down at 4 degrees.
And is that for the EDTA tube and the Streck tube, or just the EDTA tube?
Off the top of my head, I'm not sure about the Streck tube. I know that we do both at 4 degrees, but I'm not entirely sure if it needs to be done for the Streck tube at 4 degrees. It's just something that we've always done. Yeah.
Okay. All right. Awesome. Thank you so much. Thank you.
I have a question, and it's great talk.
Thanks.
When you mentioned in the slides, you said, the low frequency of the mutations identified in the cell-free DNA, the clinical implication is questionable. So what kind of a frequency you will feel comfortable to call them, and then with clinical significance? For example, if you see some resistant mutations, of course we want to as low as possible, but what is the cutoff you think will be reasonable?
That's really, yeah, I probably have to go with what I think, because there's definitely no, I guess, set protocols for this sort of thing. With the low frequency mutations, it also depends on what else you can see in the ctDNA. So for example, if you've got an activating PI3 kinase pathway mutation at 50%, but then you've got another mutation present at 0.1%, that's clearly subclonal, and I would say it's less important in terms of how a tumour is going to react to treatment. However, if the only somatic mutation you can find is the really low variant allele frequency, I would say it has more clinical significance. And I think more importantly, rather than the variant allele frequency, is whether or not you think a mutation is clonal or subclonal is going to impact treatment choice.
Thank you.
Heidi, do you do any validation and
Yeah.
I'm just going to mute that person. Thank you. Yeah, so is there a gold standard for validations if you use the next gen type of assay?
Yeah, that's a really good point. I probably should have put something in my talk about that, but there's no gold standard, I would say, for assay validation, but what most people are using these days as, I guess, a sample of known true positive somatic mutations are like synthetic plasma samples. So Seracare is a company that you can buy synthetic plasma off, they call it, that has a list of mutations at different variant allele frequencies, point mutations C and Bs, that you can run through your own assay from start to finish, and then go back and look and see whether you can identify mutations at different variant allele frequencies. If you don't want to start from the plasma stage, you can actually just buy the DNA itself and spike it into plasma, something like that. But yeah, I would recommend Seracare, I think, or a synthetic plasma sample for something like that. I think it's the easiest way.
Do we have any other questions for Heidi? Okay, so while people keep thinking, can I ask you a question about why do you think there's no standardized protocols, and why we are not ready yet for implementation in the clinical setting, and what is required to get us there?
Okay, juicy. Why there's no standardization? I just think the research hasn't been going for long enough, and we still don't really know what the best method is. I guess everyone has their opinion. Some people, obviously they've spent 5 years setting up their own assay in their lab. They think that's the best option. And a lot of people are using the commercial assays, and they trust commercial assays a lot more than in-house, but they also have their own limitations. So yeah, I think that's a real problem in generating a consensus. And I think hopefully in time, when there's more clinical trials, there will be more of a headway in one single direction, or whichever direction is best for whichever clinical question you have. In terms of what's in the way at the moment for clinical implementation, it's definitely the lack of consensus. It's also the fact that we, especially in high throughput assays, identify a lot of somatic mutations that we don't know their effect. Like, we still are identifying somatic mutations or variants of unknown significance. I know you don't like it when I use the word mutation, sorry. Alterations that have unknown significance. So we need a lot more preclinical or basic research as well to be integrated with these sorts of assays before we can, I guess, understand fully what different alterations mean in terms of protein expression, for example, and also cost. So a lot of the assays are really expensive. And before FDA approval of the Guardant assay, for example, patients were paying out of their own pocket in America up to $10,000 for ctDNA analysis to be done on their samples. So that's obviously not a viable option for most humans in the world. So I think with increasing clinical trials and the more robust data we can generate, hopefully, I guess pharma companies and the government and things will start to become a bit more confident in these kinds of assays, and that would make them financially more feasible as well.
So another question I was going to ask you is, do you think because your assay uses a targeted panel, and I was going to ask you, do you think we should move to whole genome sequencing and maybe whole genome long read sequencing? But I think what you're saying is that we can barely interpret what we already can do.
Yeah, we can. Yeah, we generate so much data that never gets touched, I think. We focus on what genes we're interested in or what we already know. And I think a lot of research labs just as sitting on a goldmine of data because there's not enough bioinformaticians at hand to go through it all. In terms of long-read sequencing, that's really an interesting point because that is going to help us with structural variant detection and CNV detection. And I'm starting to more and more like the idea of combining different techniques together to get as much information as you can, but I know that that's sometimes a pipe dream.
Sam has a question.
Hi, Heidi. Nice talk.
Thanks.
I was just wondering, I saw in your graph about detection of ctDNA in the blood that glioma is very, very low.
Yeah.
That's probably not a surprise because of the blood-brain barrier preventing it from getting out. I was wondering if they had any better detection in the cerebral spinal fluid. And also, in terms of the type of tumour that a glioma is, it's a highly necrotic tumour. I was just wondering whether there's any changes or differences in the ctDNA size profile of a necrotic versus apoptotic release of this ctDNA, and could it be being missed during their screening?
Yeah, okay, so firstly, there have been some studies in glioma probably coming out in the last 2 years where they use spinal fluid. Most of these studies I think are as a diagnostic, but yeah, I think that's probably a more amenable way to do research where the blood-brain barrier is an issue. Obviously, that increases the invasiveness of a liquid biopsy as well, and comes with its own risks and associated morbidities. What was your other question? Go again.
The any size differences between ctDNA released from apoptosis versus necrotic?
Yeah, so the amount of DNA that gets into the bloodstream is also has to do, I guess, with the vascularity of the tumor as well. So obviously a lot of necrotic tumors have low blood supply, but you do get, some release of the really large necrotic fragments of DNA that you can get in the bloodstream. I think they do get chopped up a bit in the blood, because when I look at a size profile, even before I do any size distribution analysis or anything like that, there aren't that many DNA fragments over 500 or 800 base pairs, but that could also be the kits we use, because they've been made specially to extract DNA and retain DNA that are shorter fragments in size. So that's a good point. And I suppose, the answer is we could probably be missing some larger necrotic DNA.
Thank you.
We have another question from Dan.
Look, I have a question regarding translocations. Have you been able to find them in, cell-free overall, or specifically in ctDNA? And if so, have you actually targeted both partners? And if you found them, how did you do the alignment?
I wish I could give you a good answer to that, Dan, but I haven't identified any translocations. My panel is mostly for point mutation C and V identification. Because I have a prostate cancer designed panel, I haven't really been interested too much in identifying translocations, but I can imagine, unless you know the exact spot where it usually occurs in most patients, you're going to miss it with targeted panel and short read sequencing. So I can't answer that question, sorry.
Yeah, okay, thank you.
Okay, do we have any more questions? Well, if not, I think we can finish up early. Thank you again very much, Heidi, for your presentation. Thank you everyone for contributing to the discussion. You can keep up to date with upcoming tech talks. We'll resume in February 2023, and you can also find information about the precision cancer seminars and other MPCCC activities on the MPCCC website. You can subscribe to the newsletter or follow MPCCC on Twitter